All right. Well, good afternoon or morning. I don't know, if you're in the East Coast, we're just hit the afternoon. Outside of that, it's the morning where everyone in the US. But thanks for joining us today for this very important webinar on the impact of Medicaid expansion. I'm so excited for our panelists that we have here because these are the true experts. They've either helped expand Medicaid, they're dealing with the expansion of it, or they're hoping that they're fighting for their state to do the same as these other states. So I am super excited to have our moderator, Orriel Richardson, JD and PH. Give her all her all the things she's worked for. She's a 40 under 40 previous 40 under 40 winner at NMQF, and she's also worked at both CMS and the Ways and Means Committee, working on Medicare, Medicaid issues. So I think she's probably the best person in the world that could lead this conversation, this discussion. So I'm going to turn it over to Orriel.
Thanks so much, Brandon, and thanks again to the NMQF family for having me and for convening such an important conversation with what I think is a rock star group of ladies. Not missed on me that this is a group of strong, dynamic Black women who will lead us in this conversation this afternoon over here in DC. So again, this conversation is about Medicaid and the expansion of Medicaid, or not expanding Medicaid, and how those policy decisions can really be helpful game changers for the residents of states, and or result in some populations continuing to see challenges in achieving their best possible health. So without further ado, I'm going to do my best to give an abbreviated introduction of each of our panelists, and then we'll dive into what I hope will be a very robust discussion. If there are questions, you can generally, I think, include some of those in the chat, and as much as possible, we'll try to weave some of those into the conversation that we're going to have. So first, we have Dr. Shantel Hebert-Magee, who is Chief Medical Officer for Medicaid at Louisiana Department of Health. She is a cytopathologist and also Associate Professor of Pathology, affiliated faculty at the University of Central Florida College of Medicine. As the founding director of academic pathology at the Center for Interventional Endoscopy, Florida Hospital, Orlando, Florida, she brought a vision of academic medicine to community practice. An author of more than 50 peer-reviewed publications, editorials, white papers, and book chapters. And in 2015, she launched Under the Scope Foundation, a not-for-profit organization using microscopy and pathology to mitigate the socio-behavioral and environmental factors associated with pancreatic cancer in underserved communities. Next, we have Dr. Yolanda Lawson, who's founder of Madewell Obstetrics and Gynecology, and associate attending at Baylor University Medical Center. Dr. Lawson has a genuine passion for the physical, emotional, and overall health of women, and maintaining the excellence of which Madewell Obstetrics and Gynecology was built upon the principle of providing superior organic health care with diplomacy, concern, and respect. She's also president-elect of the National Medical Association, a member of the American Medical Association, the American Congress of Obstetricians and Gynecologists, and the Dallas County Medical Society. She also sits on a variety of boards and volunteers among many other community activities and organizations. Last, but certainly not least, we have the Senior Director and Head of Government Affairs for APCO South, L.T. McCrimmon. She is former Director of Legislative Affairs for North Carolina Governor Cooper, and former Director of Government Affairs for the North Carolina Department of Health and Human Services. She is a proud graduate of Shaw University and holds an executive master's in public administration from NC Central University. Ladies, welcome. I'm looking forward to this very robust conversation. So, as we know, Medicaid expansion was a key aspect of the 44th President Obama's flagship legislation, the Patient Protection and Affordable Care Act, now affectionately known as Obamacare. And one of the things that resonated was the sort of geographical overlap of those states that did not do the Medicaid expansion uptake from the ACA, and those states that had some issues with integrating civil rights in the mid-1900s. And so when we think about sort of the history of those states, the racial demographics of those states, and the economic outlooks and status of those states, I just hope that we can sort of weave those things into the conversation that we have today. So I'm going to take Louisiana girl privilege and start with Dr. Hebert-Magee. Dr. Hebert-Magee, Governor John Bel Edwards won a sort of, dark horse race as governor. And one of the first things that he did when he became governor of Louisiana was expand Medicaid in 2016, making Louisiana the first state in the Deep South to participate in that aspect of the Affordable Care Act. And prior to this action, the uninsured rate in Louisiana was 22.7% among adults. So since then, can you tell us a little bit about how enrollment has changed and how the state has been able to address health and wellness through preventive medicine?
Well, I think you very eloquently summarized what has happened in the Southern landscape. I think we do have a long historical narrative of having a dichotomous society where we have those who are part of systems that allow for them to participate in healthcare, have educational and economic opportunities. And then we have segments of our population who have been marginalized and who have been more vulnerable. And I think a part of Southern tenets is to have federalistic policies that normally allow for large state impact in minimal federal oversight. So it was a monumental task to get Medicaid expansion in Louisiana because the very core beliefs, which have been exalted by people of different demographics, are part of the fabric. People believe in picking themselves up from their bootstraps, even when they don't have boots. So the impact of Medicaid expansion has been tremendous. As you mentioned previously, it was in the double digits of people who were uninsured. And now it's less than 10% of people who fall within a coverage gap. I think there has been a lot of there's been a lot of supposition that people are would not take advantage if they actually did have access to healthcare. I think there's stigmatization when we look at the Medicaid population, and oftentimes providers complain that they miss appointments or they don't show up. And the reality is that because we have allowed for people to enroll under Medicaid expansion, there have been over 700,000 people who immediately, began their enrollment process. But the bigger takeaway is that 90% of them saw physicians for the first time, are engaged in preventive medicine services. So the reality is when people have access and they no longer have to have competing priorities, do I pay my rent or do I try to go and see a doctor and worry about a copay or some expense I cannot afford? And when you remove these barriers, people definitely have sought treatment, preventive services, first-time services with clinicians, and it's made a huge impact. And we could talk about that more later.
Thanks so much. And that's heartening to know and hear. The sort of proof is in the pudding, the success story of what you're seeing already. I think it bodes well for some of the things that North Carolina hopes to accomplish by the actions that were taken early this year. So on March 27th, Governor Roy Cooper signed legislation that would direct the state to expand Medicaid. And we're fortunate to have LT, she functions in a space that I call people, they're just operatives. They just know how to help move the levers and get things done and get the people to the table to make the decisions that need to be made. And so I think, considering that there have been other years where Governor Cooper tried to push some comparable legislation through, I just want to hear your wisdom and your insights on the things that might have been a little different this time around and any lessons that you may want to share for some of the remaining holdout states.
Sure. This has been a 6-year process here in North Carolina. Governor Cooper was elected in 2016. He assumed office January 1, 2017. And so that was been his number one goal since he took office. And so this is his last term. He unfortunately cannot run anymore, which makes me a little bit sad. But however, he never gave up hope on that fight. And so throughout the years, we built coalitions. We kept the conversations open and we kept talking to our Republican legislature. We got our business community involved. We got our grassroots leaders involved. We got our hospitals involved. If there was anyone that had any input that Medicaid expansion was important because we understand healthcare means so much. It's just not about the overall health of a person, but we also understand when you're healthy, you can go to school. When you're healthy, you have a healthy workforce. It helps our economy. We think about the business community talks about this a lot of times is when you have a new hospital pop up, what are the other services that come along with them? That means we have new subdivisions that pop up. We have new businesses that come with them. Our mom and pop stores start to do better because you have more people coming into those areas. And so for us in North Carolina, we made the business argument, and our Republican leaders started to listen to us. And on top of that, through the Trump administration, we saw that healthcare didn't go in. We saw that health Medicaid expansion did not roll back when the Supreme Court said, this is the law of the land, it shall stay. Then we also saw when the Biden administration came along, they added on the HAS payments. And so now even our hospitals are starting to push even more because that's over $1 billion. Excuse me, it's more than $1 billion. That's going to come in just to North Carolina. And our hospitals are talking about their bottom lines and how hard they're struggling to keep their doors open because, frankly, our rural communities, a lot of those folks are using their EDs as their primary care. And so if you can't afford to go to a primary care doctor, you definitely cannot afford to pay that ED bill. And so our hospitals are absorbing those costs and they're operating in the red. And we understand in rural communities, especially, I'm from a rural community here in the state, once you lose your hospital, it doesn't tend to come back. And so therefore, now you have to drive even further to get to care. And a lot of times you have another barrier to add on top of that is transportation. And so you have all these barriers that are stacking against your folks that's in your communities. And a lot of our individual legislators were starting to hear from those folks in their districts, and they start to change their opinions because they're saying, okay, I've got this mom who's a single parent, who's working 2-3 jobs, barely making ends meet, and still can't qualify for some type of health insurance, cannot get Medicaid through the normal channels. So how do we help her? Or how do we help that family? And so through these past 6 years, getting our chambers involved, that is what changed the tide. I never forget the day I listened to Pro Tem Phil Berger stand on the Senate floor and literally sounded like a Democrat. He read verbatim Democratic talking points that we have been saying for the past 6 years. And you literally could have knocked me over with a feather because it took us to this point. But, North Carolina, we were just to one point where the language that we passed, the governor signed March 27, 2023 at 4:25 p.m. Yes, I have a copy of the legislation that he signed, but we still have one more phase that we have to get done here in the state, and that's passing the state budget, which means they're going to throw a lot more things at the governor that he would not typically sign and pass because that ties the money, the money that flows with it. They're a little tricky, but we're gonna make it work here. Ties the funding that goes with Medicaid expansion into the budget. So once we get that last piece done, we will start seeing the fruit of that labor in 2024.
Well, kudos to you and the work that you and the team and the governor's office did to be tenacious and to have the hard conversations. I'm not going to take us too far afield, but being on the Hill, that's one thing that you can talk about the people aspect of things, but at the end of the day, you have to come up with something that goes in a spreadsheet and that balances itself out. And so it's absolutely critical to be able to make an economic and business case for things. And when we talk about healthcare, which is its own economy, $4 trillion plus, and our outcomes are below that of other countries that are way down in the estimation of where we stole ourselves. It is very important to just be comfortable with stating in some sense that there is a business case of healthcare. There's a lot of money here. So being able to articulate that has been something that I think has helped move these conversations along at the federal, and it's good to know at the state level as well. And so that is actually a really good seg for Dr. Lawson, because she is in Texas As we know, there are 41 states, including DC. We hold ourselves out as a state, even though, anyway, that have not adopted Medicaid expansion. And those are holdouts, again, that are concentrated primarily in the Deep South, with the exception of Wyoming, Wisconsin, Kansas, and then Texas doesn't really consider itself the South, unless you're, the San Antonio East Side, I think probably does a little bit. So, but with Texas being a holdout, can you talk a little bit about, both from your perspective as being involved in MA and policy conversations, but as a clinician, like what are you seeing for the residents of Texas, and what types of lessons do you think are also applicable in the other states that have not expanded Medicaid?
Absolutely. Thank you. Thank you all for having me and allowing me to join this conversation. I think it's so important, for those of us who are Black physicians in this country and doing our best, right? Doing our best to take care of our people. And then when you see that, and, part of that conversation becomes access. So in Texas, it's challenging. It's challenging because I'm an OBGYN. It's challenging because I'm a Black physician in Texas. But direct impacts on healthcare, as you all know, Texas has one of the highest rates of uninsured individuals in this country, right? And so what does that mean when you talk about the health of a community? And so we know that in our legislature in Texas, there are these arguments, many of them come up around the economics, the loss of money, Medicaid's a sinking ship. These are things I've heard my congressional leaders say and talk about. But me in the trenches, on the ground, taking care of patients day for day, I think about those direct impacts. Number one, we know that if Medicaid is expanded, we see improvement in cardiovascular health. We know that cardiovascular disease is the #1 killer in this country. I don't care if you're Black or you're white or you're Hispanic. So we know that's something that could easily move that needle. The second would be cancer detection, early cancer detection. When people have access to care, they have a way to see the doctor. At least we hope that they would get those basic screenings, pap smears, mammograms, colonoscopies. And then thirdly, we know that there is an impact directly on maternal mortality and maternal health when people have access to care, and which can come in the form of Medicaid. We also know who it's affecting most. There are so when you break this conversation down, there are so many people effects. I could break down to you age demographics, regional demographics. We discussed rural, right, communities a little bit here, the closure of hospitals, another, right? When there's not Medicaid expansion, we saw these communities in these states where the closure of rural hospitals was higher. Yes, we consider ourselves in the South in Texas. I know people get confused, Southwest, South, what is that? But I consider it the South because Texas behaves, right? There is a Southern flair. It is not Western. They would not identify with that. But I say that to you because I do a lot of work on HIV. And we know right now, over 50% of cases of HIV are in the South. Those medicines, access, testing. I've had patients who their partners can't even afford an HIV test. Even our health department, it could be a scale, right, based upon income. And so there are so many aspects when you talk about access to care that are important around this conversation. I think it's an important conversation. I'm just happy that we're having a conversation.
Well, I laud your enthusiasm and your passion because I was pre-med and I often wonder if I actually had the fortitude to be a physician in this climate. So yes, I chose the other pill and I do policy and law, but to both of the physicians on the panel, I do applaud your tenacity and your stick-to-itness because it's multiple layers of not easy. So kudos to both of you. And then turning back to Dr. Hebert-Magee and kind of piggybacking on what Dr. Lawson was talking about, you have the ability to look across some of the chronic conditions and the sort of burden, the disease burden in Louisiana and sort of see point in time now how the Medicaid expansion and improved coverage for the citizens and the residents of Louisiana has borne out. So can you talk a little bit about like, the trope of are people accessing the benefits that are available to them, and sort of how long it took for your data to show that Medicaid expansion was working to improve the health of Louisianans?
So I would say that, that's a very complex question. Obviously, we know that some outcomes are going to take a while because there has been generational impact. While you can get a patient into a physician's office and check their blood pressure and even provide them with a blood pressure cuff so they can do self-monitoring at home, if you're not tackling the underlying issues, so if there is food insecurity or if they're in a food desert, they're going to buy food that has lots of preservatives, canned goods, things that have salts in them. So despite trying to make heroic efforts through medication management or even trying to get them on a diet, we know that there are still barriers that are not within, are not confined to the healthcare setting itself. It's interesting that the South, we typically have more temperate climates. We have huge swaths of land that are for agriculture, yet we have people who still have sedentary lifestyles, or they're so spent from working as essential workers, menial jobs, day laborers, that they don't have the capacity to be able to say, I'm going to take and go for a walk. Or there may be violence in the community that is not even safe because they don't have street lights. And so there are many factors that have stifled some of the progress that we're hoping to see in the outcomes. However, we have been able to detect colorectal cancer, cervical cancer, breast cancer, more readily, getting people into treatment programs. So they're able to access therapeutic modalities as soon as possible. And we know the earlier detection occurs, the better outcome for so many of our Medicaid beneficiaries. As mentioned by the two other panelists here today, is that when we think of Medicaid historically, right, people think of welfare queens, and the media has always portrayed it as an urban issue. And if I'm speaking as though it's just you and me, a lot of our Medicaid enrollment has happened in rural communities. And so it's an issue of rurality. And when we look at that, particularly when it comes to uncompensated hospital costs and the care, we've seen a huge decrease. So when people talk about the economics of Medicaid expansion, it has helped Louisiana tremendously. So our rural hospitals, the uncompensated care costs is 55% decrease, meaning that the total expenditures of these rural hospitals have decreased by 55% when it comes to uncompensated care. So they're still able to keep the doors open. And so people are still able to go and receive treatment. We've diverted people from using emergency departments and urgent care centers because now they do have primary care physicians who are able to see them. But also, we're thinking outside of the box. We've had stakeholders come to the table who are adding incentive programs and value-added services. So they're providing transportation, GED classes, things that are going to address the underlying issues, realizing that health is not in a silo. And because they now embedded and enmeshed and we've created with Medicaid expansion, they want to see it thrive. They want to see the outcomes. They want to see the improvement. So I think we're making the steps, and we are seeing through our preliminary data that people are utilizing the services, that they're being seen readily, that they're getting access to preventive services. We're catching cancer earlier than, and we know particularly in African-American populations, we have late presentation, advanced cancers. So we're able to do more. It's more cost efficient, but also, we're able to, as Dr. Lawson had mentioned, when it comes to STIs, we're able not only to treat our Medicaid beneficiaries, but also their partners. So therefore you prevent reinfection. We're able to give people PrEP, so therefore we are reducing the transmission of HIV. And so because we have an infrastructure in place, it allows for us to not only tackle the bread and butter, the chronic comorbidities, because unfortunately, the South has some of the worst health metrics, and Louisiana ranks high in many of those. And so we want to see the needle move, and we want to see improvements. And I think that Medicaid expansion has been the catalyst.
Orriel, I want to comment on something Dr. McGee just stated. I had a recent incident. So in Texas, there is a product called Texas Healthy Women. It's a Medicaid product. It was one of Texas's responses when they did not expand Medicaid for the outcries for coverage for women, right? It pays for basic STI screening. It pays for a pap smear, and it allows me contraceptive counseling. If someone needs an ultrasound, they have a mass, it does not do that. It is for prevention only. I recently had a young woman who was diagnosed HIV positive when I tested her. It allows me to test. That's all I could do. I actually got on the phone. I called Medicaid myself. I couldn't do any of the other additional testing she needed. I could not prescribe medications for this patient. I could do nothing. And so so it's overwhelming what we have to deal with. So you talk about the fortitude to be a doctor, and you're right. The environment. We talked this morning a little about the political determinants of health, right? And so the environment that we are, especially when you're a physician, you have the tools. There are resources and things and medications that will help your patients, but you're not able to, right, to help them, assist them, just because of the structures that exist. So I just wanted to give that, because it's looking at the dichotomy of where I am and what she's saying where she is and how far Louisiana has come with this. It's so important to get this word out.
Yeah, we have better continuity of care, and that's what you're speaking about. It's one thing to be able to diagnose. So many times we do screening, particularly when we talk about pregnant women and women who, are coming into clinics, and we're trying to screen and determine if there's any depressive disorder, if there's behavioral health issues, if there's substance use disorder. And the clinician can do the screening, but they may not know how to connect them to a mental health therapist. And so we've been closing the gaps, reducing the chiasms, because we have a system in place. You can't piecemeal things and put it together and say, oh, this is going to be our proxy. This is going to be our surrogate. No, we're not going to expand. And in lieu of that, we're going to toss you a bone. That is not suffice, and it's not going to deal with the issue. And the issue is that you have to break down some of the structural and, social inequities. And it's hard conversations. It's, talking about disparities is not just saying, okay, there's a difference between this race or this gender or, this particular locality, if this is rural or if this is urban. You have to get to the root underlying causes. And sometimes people just say, oh, it's because they belong to this racial group. Well, what is it about that racial group? It's not genetics. We know that it has to do with the social and the political and the economic, issues that they face. And oftentimes they are stifled. They are marginalized, and we have to address those issues. And I think sometimes, our governing bodies think that if you do something, there should be an immediate response. And so they want to see immediate gratification, this microwave, instantaneous, result. And I'm a Dewey Decimal girl. I went to the library. I had to look on the shelf. I had to find the book. The book not there. You got to go somewhere else. You got to ask the librarian. Go to a different source versus just someone handing you something and saying, here you go. It's on Wiki. So our response to healthcare is not a wiki response. It's not going to be like, okay, this is how you're going to tackle this. It takes tough conversations. It takes having engaged stakeholders. It takes having governmental support, oversight, and understanding all the various intricacies in order to move the needle.
Okay, jump on in there.
So this is a very good conversation, and I just want to segue one thing we're doing here in the state. Before we even got to this point, under Dr. Mandy Cohen, who was our Secretary of Health and Human Services, the governor tasked her with, how do we look at the tools that we currently have in North Carolina, and how do we all bring them together? And so what we started was the social determinants of health. And I saw the question in the chat. And so what we've done is we looked at all the pieces of the puzzle, and we broke down those barriers, and basically we housed it together. So what we're looking at the whole person. And so if you are food insecure, how do we hook them up connect them with food? If you're living in a food desert, if you're unhoused and you need housing, how do we make sure you have housing? Or if you're in housing and we know the carpet that is causing breathing issues, or your kid is having asthma flares up, your kid's asthma is going to flare up, how do we pull that carpet out and get you better flooring? And so we're breaking down those silos. And so we're trying to better align all of our tools so we can take care of that whole person, because we didn't have Medicaid expansion, but we do have tools, and we do have folks in our different communities that we can align together, that we can use. And it was something that we've seen that works. It works very well. It worked to the point that CMS has taken notice. And CMS is working with North Carolina Department of Health and Human Services. We have a pilot program that we're working with the first in the nation. Hopefully all goes well. We can then deploy it to all of other states. That way we can use our model, and we work with other states to make it better. So whatever we have done, I hope Louisiana, Texas, so forth and so on, can improve upon it, so we can make sure we're taking care of the whole person in every state in this country.
That was great. And it sort of took me off my script here, which I love. But one of the threads that I want to pull out and talk a little bit, and it's just bear with me while I try to flesh this out. So part of, I think, the conundrum that Dr. Lawson said is we have the ability to know there's a problem, but not the tools to do anything about it. And I think when you consider that issue alongside what it takes to really attract, for example, specialists to a region, an adequate workforce, I think there is that element of what Medicaid expansion does as well. Like, we talk about hospitals a lot, particularly because, for example, in North Carolina, hospitals and financing of hospitals is very important to Medicaid expansion success. And hospitals offer a lot of revenue, frankly, for most states, just based on how licensing and certification fees and all of those things and taxes are sort of baked into how states finance healthcare. But I think there's something that we should sort of unpack around Medicaid expansion, not just as something that helps to fuel the economy and business, but as something that is going to literally make or break the ability of the healthcare workforce to meet the need when we're already experiencing shortages, and post-COVID, some significant burnout and attrition across those professions. So anyone want to jump in and tackle that easy question I just lobbed at you? Feel free.
I mean, I'll jump in there. One thing that we've got a lot of teaching schools, teaching hospitals here. So ECU, we got Carolina, Duke. And also, again, I talk about Department of Health and Human Services. And so one thing that we do is we work with those schools to get that workforce here, to educate them. And then also one thing ECU does that I think is really brilliant, part of that debt, if they stay in one of those rural areas, kind of helps pay back some of the student loans. And so we work with HHS also to get some folks who are not from this country. We'll help them get their visas. I'm forgetting the name of the program, but just know my knowledge from my time working at the department. We work through that department to make sure that those folks go to those rural areas. They're there, they get integrated in those communities. And when I say integrated, that means you're living there, you're going to church there, your kids are going to play t-ball, or you're part of the community. So when folks see you out, they know hey, I'm here and I'm here to stay, because not only am I here to stay, it's also beneficial to you, because now you're not going to have a bunch of debt that you're going to be settled down with. And so the more that we get funding to those schools, the more educators we get there, the more doctors, the more nurses, the more PAs we're putting out. So that's what we're doing in North Carolina. I'm interested in hearing what they're doing in Texas, Louisiana, because what we can, what I can learn from you all, I would definitely take it back to the governor and other folks in the state.
No, to piggyback off of what you're saying, I'm in complete agreement. Numerous studies have supported that people get better care when there is shared cultural identity. So, so to have people who are from rural communities stay there and become embedded and part of that fabric and share that DNA, that has been something that we are promoting in Louisiana through similar pipelines. Similarly, Xavier is going to be opening up a medical school. But prior to this, we've been trying to increase the number of underrepresented minorities because there is a dearth when it comes to healthcare practitioners. And we know that there are some nuances and perceptions, implicit biases that still persist. And to have someone who's cut from the same cloth, who shares your social and ethnic DNA, it makes a huge difference. And so we cannot dismiss that. And so that is a priority within the state as well. In addition to that, we have these early learning programs where we are trying to expose children to healthcare careers. We've actually started in preschool. There has been white coat ceremonies, and we continue this in the elementary, high school, and in the pre-graduate study curriculum, and ensuring that not only is there exposure, but there's true mentorship, sponsorship, and coaching. So we need to sponsor opportunities for them to have internships and participate in activities, also continue to coach them through some of the extraneous factors that may impact them pursuing careers that impact our healthcare workforce. This is a very complex situation. And so moving away from our pipeline programs, we've also tried to increase our rate. We know that Medicaid does not pay what Medicare and private insurance, pays our providers. And so we've been trying to get providers enrolled as Medicaid providers, but also really monitor and see how many patients are they actually seeing, because we have many people who are enrolled, but they only have few slots that are available for Medicaid recipients. And we believe because there is still these biases that exist. In addition to that, we know that our patients have more complex social needs. So we try to integrate that through Medicaid expansion by providing case management and care planning. So we don't have patients that are missing appointments because of transportation issues, or because there isn't a specialist who is in close proximity to where they are, or they have childcare issues. We're trying to find mechanisms to ensure they're getting the care that they need, and it's having robust conversations and having a lot of thought leaders, subject matter experts, to ensure that, it's not just about, the financial piece and how it's going to increase and stabilize our economy, but ensure that we're going to see the improvements in health outcomes, that people are truly self-actualizing and reaching their full potential and not being hindered by health and wellness. So we are trying to take a comprehensive approach.
Dr. Lawson, how is it attracting specialists in Texas and a robust workforce?
Absolutely. So it's challenging. In my specialty, OB-GYN, of course, there's huge concern on the pathway and the pipeline to the workforce, right? Because physicians in the women's health field, right, of course, would have legitimate concerns. There's also the concern of the pipeline in the pathway up into the development of our workforce. We know currently we're dealing with certain threats, right, to achieve that racially concordant workforce that Dr. McGee just referenced. This fairness admissions trial versus Harvard, the one in North Carolina that's coming before the Supreme Court this summer. We know that we are on the edge of our seats waiting on that. We know that for the last 50 years, we've been trying to get to this place, right? You all have seen the data, 5% of US doctors, right, are African-American, but we represent 13%. How do we get to racial concordant care? So there are several threats that jeopardize us getting there. The second thing from the Medicaid aspect that I have to say, and I hope, and this is something I think even for those of you who have expanded Medicaid, I'll tell you personally what I've seen. There are not a lot of, and I think one of our legislators in Texas said, Medicaid is coverage and not care. In my area where I work, there are many physicians who do not accept Medicaid because of this lower reimbursement. I just met a doctor, I'm in Chicago. I just met a doctor here yesterday. She said, I'm working 6 days a week because I only get reimbursed $41. Because I'm like, doctor, why are you working? She said, I get reimbursed $41 for full evaluation. And so so payment parity, so from the National Medical Association and an organizational strategy, we're looking at some of this advocacy, provider advocacy from the payment strategy. At the federal level, right, there is, I actually went to the HHS secretary. What can we do about payment parity? It's a state issue. So while your states, and while you've expanded Medicaid, I still encourage you that there is still work to be done, because while you may have your community and the people subscribe, you still need providers. And many providers don't take or accept Medicaid because of the payment and the reimbursement. And so there is still significant work to be done. And so while we're not expanded in Texas, there's still work for us to be from the provider advocacy piece is around the reimbursement piece with Medicaid. So I just wanted to bring that up because there are so many tiers and levels and aspects to this struggle and then to advancing, right, these access to care issues.
So I think we could continue to talk probably for much longer than we have appointed at this time, but I would want to touch upon a couple of things just before we go and turn to the questions that we've received from the attendees. And one is just thinking about, and I guess I'll pick up on what you're talking about, Dr. Lawson. There is, I think the NMA calls itself the conscience of American medicine. And so with that in mind, and I won't get into the history of why the NMA can call itself that and the AMA cannot and all of those things, but thinking about what the role of the physician is in advocating for not just Medicaid expansion, but as you mentioned, a sort of like consistent level of payment that allows those clinicians that serve vulnerable populations to make their payments, meet their mortgages, live a life that they thought they could live when they took that learned profession. Can you talk a little bit about what you envision as you assume the mantle of leadership of NMA for advancing that conversation and trying to bring in some of these aspects in the states that have expanded, but also so that the states that haven't don't get bumped down in the list of places where the new graduates and the new clinicians would like to make their lives and careers?
Absolutely, thank you. I'm going to share this with you all. So yesterday I was on a meeting whereby the AMA Center for Health Equity kind of has put together entities and organizations from different demographics, the NMA, the AAIP, or the Asian American Indian physicians, the Native American physicians, the Hispanic physicians, those physicians who represent the interests of the LGBTQ community. So we're looking at all these entities, right? All of us were on this call that want to advance equity. So I get on the meeting, I'm like, oh, great, another coalition. Because as you all would agree with me, over the last 3-4 years, we've seen multiple, everybody's working on equity, right? Everyone's working on equity. So, but what I took away is that all of us on this meeting, there were about 2 or 3 things that we all aligned on, And that's really been, this past year has been a study on who aligns with our missions and what we're trying to do. And who can I garner and engage, right, to make impact on these issues that matter. And in what the number one, right, where we all agreed on, no matter what your demographic was the workforce, the healthcare workforce. Everybody sensed that. I thought it was amazing. The second thing was diversity in clinical trials, representation. And then the third thing was payment, right? And so here we are again at this place where we have to reckon. And so I looked at the coalition partners and I asked the question, you have gotten an impressive group of people to partner on this initiative, but are they really ready to do the hard work? I mean, it was literally my question. I can't be another part of another coalition, but we're not answering the hard questions. And we're not really depressed to do the hard work. And I don't want a shiny report, right? It looks great, beautiful, credentialed authors, but I'm ready to see some ground level impact. I want to see the change, if you will bear with me on that. But I want to see it. And how does it manifest? Whether it's a metric, I asked, what are going to be our metrics? Who's going to decide what we work on? And are we ready to do some really hard work? So I am looking forward. I welcome anyone to partner with who is interested in doing some impactful work. Someone used the term earlier that moves the needle, makes our communities healthier, closes the gap on healthcare disparities. And it is, again, all these entities, and everybody's worked on equity, but who's getting it right? I don't have the answer to that.
No, you couldn't have said it better. I definitely think that we have a lot of ideation, but not enough action. And, you know, another plug for Medicaid expansion with our managed care incentive programs. We are doing quality metrics. We are looking at the outcomes, and we're delving into areas that normally wouldn't be considered healthcare. So we're trying to tackle community violence. So, you know, hospital violence intervention programs and people coming in with gunshot wounds, looking to see how do we prevent, you know, re-injury, because the likelihood of being shot again or being murdered is considerably higher for people who present the first time. So it's not just about reducing the cost of, you know, the emergency care. I mean, I've talked to our MCO, and, you know, they were very intrigued that sometimes people have lifelong conditions, whether they're left paralyzed, whether they need colostomy bags. You know, these injuries mean that they're going to be part of the healthcare system for a substantial period of time and incur significant cost. But it's not just re-injury, but it's also retaliation. Are they going to go back out and do this to someone else because what has occurred to them? How do we address this? And because of Medicaid expansion, we're able to get violence intervention specialists. We're able to get community health workers. We're able to get patient health navigators. We've been able to have meaningful conversation, but also create momentum in action by saying, okay, this is the charge. We need to determine how do we do this. Of course, the first step is trying to get the data, seeing where we are. You have to have methodology. But the next step is actually putting that data into action and saying, okay, this is going to be our first objective, or these are going to be our 5 PIPs. This is what we're going to work on, and see which ones are successful and which ones aren't. And the ones that are successful, my biggest concern is sustainability. I think that right now there's a lot of win when it comes to equity. There's a lot of win when it comes to trying to, you know, address provider shortages and to shore up the deficits in rural areas. But I don't want it to be the next hot topic. I want us to truly become enmeshed in this, and this is something that we actually try to continue. I don't want us to have different objectives under our incentive programs through Medicaid expansion, where they're changing, every 2 years, and we're really not seeing, a significant impact. We see this peak and then a trough. So we have to have sustainability, and sustainability, obviously, there has to be something that is grounded and rooted in our economics. And we have to have that support with our state general funds. And I know those are tough conversations with our legislators. So, yeah, that's my last bit.
Oh, Dr. Hebert-Magee, you teed that up perfectly, because I was going to LT and I was going to ask LT, looking at all these different pieces and knowing that Medicaid, the population, the known needs there. And I say it that way because I'm working on the commercial side of the house now. And if you look at people by income and or wealth, it's the same story as you see in Medicaid, but that's a conversation for another panel. But the idea of where North Carolina is demographically, looking at how the economy is shifting, looking at how, for example, they're courting, like Apple is in North Carolina. There are a lot of world-class corporations that have come to North Carolina. Can you just talk a little bit about how some of those sustainability issues, some of those just kind of needing to shore up the overall demographics of North Carolinians was instrumental in making the case for what you all did to pass the legislation to expand Medicaid?
So, this is a very good conversation, because Dr. Lawson, I couldn't agree with you more. Lawson, excuse me. Coalitions, they're great to have, but if we don't have measurable outcomes, we're not seeing the needle actually move. That's all we're doing. We have a coalition of having a conversation, and that's cute, but it's not getting the job done. But with that being said, for us in Carolina, having the coalition is what helped move the needle. It helped get us to this point. We became #1 to do business in the country because we pulled together Republicans and Democrats alike, business leaders, because we wanted to attract more companies and have more headquarters here. This is why we have Apple. So I think about Secretary Michelle Sanders, phenomenal sister who I have nothing but the utmost respect for, who's doing a fantastic job, who is the Secretary of Commerce here in the state. She's went out and she's attracted these large companies that want to relocate here, but the kicker is you got to have the workforce. And if you don't have a healthy workforce, an educated workforce, who's going to do the work? And so we want North Carolinians to have those jobs. But if you don't have those folks in place in North Carolina, so that's when folks from Louisiana, Texas, and from around the country and around the world come here, and they're supplanting our folks for those good paying jobs. And so that was another eye-opening moment for our legislature. They want these mega sites to be in their districts in these rural areas, because that's where a lot of our leaders are from, our rural areas, because our urban areas are more democratically leaning. I think that was a big eye opener for them. We had what's called Wolf Speed, I think, in the triad, and again, that's Phil Berger's area. Well, Phil Berger, you want folks from your district to get those good paying jobs. Guess what? You better make sure they're healthy so they can get up and go to work every day, because they want those $70,000, $80,000+ jobs every day to feed their families. And so when you start talking dollars and cents, people start to listen. And so that's what worked here.
Sorry.
Go ahead.
Okay, I'll be remiss if we don't touch on a question that's in the chat that really delves into racism. And having 4 Black women on this call, I think we have to tackle it head on. So I would say, how do we get buy-in from those non-expansion states where we know that racism may be contributing to some of the reluctance? And I would say that in the early 18th and 19th century, we had a disease that ravaged African-American communities. It's called pellagra, and pellagra is caused by vitamin deficiency. And it was believed to be inherent to being Black. And so people would not only have, very painful sores and skin condition, but it also led to hallucinations. And when white people started experiencing this disease during the Great Depression, because they were also malnourished, that's when they began to fortify bread, and we got Wonder Bread. And in short, it became a national issue. We've had various iterations of this, whether it is HIV, initially being an issue of those who belong to certain, whether they were IV drug users, gay men, Black women, and it was a scourge, and people felt that this was God punishing certain segments of the population. And when it became widespread, once again, it garnered attention, and there was momentum. And the same thing with the crack epidemic and now the opioid epidemic. People only are concerned inherently about what affects them. And if they don't think that there is any buy-in, there is no benefit to them expanding Medicaid, it's going to be a Black issue. It's going to be a Hispanic issue. It's going to be an undocumented issue. It's not going to be something that is universal to ensure that everyone in society has access to healthcare coverage so they can thrive and contribute to society. So the only way that we're going to actually move things in a progressive manner is to have an open, frank conversation and change the narrative. This is not to ensure that only Black people get access. No, we have to talk the numbers, show the empirical data, and show where the largest uptake is in how it benefits populations that have been under the radar, and therefore how it benefits the entire society.
I was going to turn to that question because first off, LaShira Nolan, good question, great reference. The last time I did an NMQF panel, I told everyone they should read that book, Dying of Whiteness. Dr. Metzel nailed that. And as a man writing this book, it's even more compelling because it's not just healthcare. It looks at a couple of different issues. And I think for Texas in particular, and my sisters in Florida, there is a heavy complexity of the immigrant conversation and the conversation we need to have with our Latino brothers and sisters to really talk about what it looks like to stop allowing privilege and supremacy to other us against the others. And that is, that's the story, but it's also the history of people assuming Medicaid was for poor people or then transition to being like, oh, well, white people aren't poor. It's mostly for Black people, the welfare. So there are historic tropes there. And I think an active coalition, I'll say it that way, since we've kind of put a little asterisk by the passive ones, an active, assertive coalition has to be one of the things that really starts to have the drumbeat of moving those things in a positive direction. We have 2 minutes left, and I don't want to be the last one saying something, but I had to throw that in. Like, LT, did you want to chime in? I thought I saw you.
I just wanted to say, for us showing the numbers of the racial breakdown didn't work. Didn't move the needle one bit. Showed them it wasn't Black people, it wasn't the Native Americans who were the highest. That didn't have health insurance, that were under or didn't have insurance. It was white people. It was a white vote. Let's just be country and say what it is. When I started showing them dollars and cents, that's what moved the needle. And that's all they cared about. In my state, they care about money and how they can get it and how they can spend it.
Having come from the Committee on Ways and Means, which holds the purse of the United States government, I have learned that the economic and the dollar conversation is most compelling. And it is a way to have hard conversations about all of the historical discrimination and racism that has happened in the United States. But I am invigorated having had this conversation with the three of you ladies this afternoon. I thank you so much. For the person in the Q&A, the name of the book is Dying of Whiteness. And for the other question about FQHCs and non-expansion states, I apologize we didn't get to it, but if you reach out, we will provide you with some context on that as well. So thank you so much for spending an hour with us. It went by pretty quickly. Thanks again to Dr. Hebert-Magee, Dr. Lawson, and McCrimmon for sharing their insights. And I look forward to finding all of you in your respective geographies and giving you a hug at some point in the future.
Here, hug.
Have a wonderful afternoon and look for the next NMQF webinar announcement. Have a good one, everyone.